Hello, I'm John Boyages, the Director of the Westmead Breast Cancer Institute, and welcome to our 2011 Public Forum, Moving Forward, Surviving Breast Cancer. This is an interactive forum on health and wellbeing after treatment for breast cancer. Tonight we have an expert panel of health professionals to talk about the latest research on the role of physical activity and nutrition in breast health and how women and a few men out there can get the necessary support and follow-up care they need following their treatment. The program will also discuss ways in which healthcare professionals can assist women after their treatment. There are a number of useful resources and links to websites available on the Rural Health Education Foundation's website, rhef.com.au, and specific breast cancer information at bci.org.au. Now, let's meet our panel. Jude has been a McGrath breast care nurse for over 4 years in the Albury-Wodonga region. Albury-Wodonga was the first rural and regional area to have a position funded by the McGrath Foundation. And Jude, what a great initiative that the McGrath Foundation, as a legacy to Jane, and funding all these nurses right across the country.
Absolutely.
Welcome.
Thank you for that. And yes, the McGrath Foundation does wonderful work, and it's an honour to work for them.
And thank you for coming. And tell me about what your normal week involves.
My normal week often involves meeting women who've been newly diagnosed with breast cancer, and men, of course. I meet them at diagnosis, then I see them before they have their surgery, after they have their surgery, at the results appointment, and follow them up through chemotherapy and generally radiotherapy and afterwards.
You sound very, very busy. So do you have a family life as well, or children?
I am busy, and yes, I do have a family, so I make time for them as well.
Fantastic. Thank you, Jude. And our next guest is Kelly. Kelly is an accredited practicing dietitian. She's involved in the clinical care of patients at the Westmead Breast Cancer Institute. And thank you for coming, Kelly. And
thank you.
Tell me about your normal week. Well,
my normal week would involve a clinic. We see patients and survivors at the Breast Cancer Institute. I've also got a role in research at the Breast Cancer Institute, so we're looking at some of the lifestyle factors associated with cancer development and recurrence.
Okay, and family at home?
Yep, I've got 3 children, 2 dogs, and we're all pretty interested in health and fitness. So.
You're skinny dogs? Or
they are very fit dogs, yes.
Very fit dogs, okay. All right, thanks Kelly. And Rob, welcome. And thank you for coming all the way from Perth. Tell me a bit about your normal week.
John at Edith Cowan University, we operate a wellness clinic called the Vario Wellness Clinic, and we have a lot of cancer patients that come through that, and they receive integrative support focused around exercise physiology, dietetics and psychology. But my main role is as a researcher investigating the effects of exercise in breast cancer and prostate cancer patients.
Thanks for coming, and what do you do to relax?
My wife and daughter and I love going sailing, so we've got a sailing boat and we take it over to Rottnest Island as much as we can.
Fantastic. Thanks, Rob, and welcome, Gemma. Gemma is a senior clinical psychologist working at the Westmead Cancer Care Centre in Sydney, and who specialises in psycho-oncology. What do you do yourself?
I see women and their partners with breast cancer and their families too, and I also work in cancer services generally in the west of Sydney, so I see people with all sorts of other types of cancers and their families and help them through the journey, talk about treatments, help them adjust and as they go through this thing.
So that could be draining for you. What do you do to unwind?
At times, yeah. I've got a family, two young children, an 8-year-old and a 5-year-old. Love spending time with them, love reading food magazines and reading, dancing.
I believe you like cooking as well, do you?
I do. I love cooking.
Yeah, okay. So we'll be talking a bit about food later and exercise.
Yeah.
So, and thanks, Gemma, and welcome, Jenny. And Jenny is a rural GP academic working in Tamworth. And tell us about your week, Jenny.
Well, John, I think I have the best of both worlds because I get to be a GP and have ongoing relationships with patients, which I really value, but also I get to teach medical students and be involved in primary care research. Got a passion for ensuring that our rural Australians get similar access to services that those who live metro.
Well, thank you. Thanks very much, and thank you for coming from Tamworth, and thank you to all of you for coming along. And just to mention that this program is funded by the Westmead Breast Cancer Institute, and the vision of our institute is to support women with breast cancer not only today but every day. And this is one of the key highlights that we fund every year. And thank you to the Foundation for making it possible, and for all of you for attending. We know that 1 in 9 women will be diagnosed with breast cancer in their lifetime. What does that mean? Well, today and every other day this week, another 38 women will be diagnosed with breast cancer, almost a classroom full of people. But we also know that most women who we treat with breast cancer will survive the disease. And in fact, 97% of women who are diagnosed with early breast cancers through screening and good treatment and so on will go on and live a normal life. And I guess tonight we'll be talking a bit about that, talking about some of those issues that women face after we cut the umbilical cord and the treatment's finished, the radiotherapy's finished, the chemo's finished, and suddenly you don't have to drive to radiotherapy anymore, or chemo visits, and a lot of our role starts to kick in terms of what tests do I have, is that little ache and pain cancer, how do I start talking to my friends again, do I go back to work and when? And so these are some of the issues and challenges that we will be facing. Just introduce Gemma again and ask Gemma what are the common psychological issues that you see in your patient group?
Look, I think it, people talk about cancer being an emotional roller coaster, and I think that's absolutely true. And the roller coaster is different for every, woman or man facing this, and it's different for their partners and their family. And I think one of the things that people expect, John, is that perhaps the roller coaster is going to stop once treatment's stopped, and that's a big surprise to women and their family when that doesn't. And actually, I have a picture which sort of summarises that, which people might like to have a look at. You can see just on there, and it's divided into the different shaded areas of when we're feeling calm, when we're under moderate stress, and then extreme stress. And you can see across the cancer journey that the stress, naturally goes up and down, as it does for any of us, really. And there are points when we're very highly stressed, extremely stressed, and that often comes when women and their families, are diagnosed, have to face this. There's lots of change and so on. And then starting treatment, and obviously these are a generalisation, but sometimes starting treatment and people know what to expect of cancer services, and emotionally you settle down a bit and get the cancer care family around, know who to turn to ask questions and those sorts of things. But then sometimes again at the end of treatment, when the situation starts to change and we pull away from being close to cancer services and follow-ups lengthen, and you're not so closely involved with medical services, a lot of emotions really flood in for women and their families, and it's pretty overwhelming actually. And there's another peak of emotion often, at that time for women.
Yeah, I guess when you see someone for the first time as a specialist, they've been waiting to see you, very anxious. There's fear of the unknown, what's going to happen, and what you're saying is things settle once your treatment starts. But then often what we forget as health professionals is that we suddenly push them out the other side.
That's right.
And there's a lot of pain and perhaps recurring thoughts and so on.
And people talk about surviving cancer emotionally from the beginning, but this term survivorship, which women who are watching this will have often read about, that survivorship phase often starts at the end of treatment. And it's that time, as I was saying, you move away from treatment, physically you change, so the hair might regrow a bit, you might start returning to work or training, normal home duties, caring. And so although some aspects of life start to look normal again, it really is a new normal. And some members of a family might expect that, mum or grandma's completely okay again now, but mum or grandma doesn't feel completely okay. And so it can be, easier said than done to just return back to normal life. And people expect that, or they assume, and families sometimes assume, that women will feel happy and triumphant and bulletproof and relieved and grateful and thankful, but actually they feel pretty sad and frightened and anxious, worried and lonely, and I've patronised there as well, and sometimes patronised by some of the things that people say around them. And well-meaning people often, people that really want to put the cancer experience behind and help a woman move on, or a person that's had the breast cancer move on. But sometimes those things can feel like real cliches and platitudes and lead that woman to feel even more isolated than she did before. And I've actually sort of put a few of those down because they're so common, and women talk to me about these all the time, and things like, it doesn't matter that your hair is short or grey or thin, that you're lucky you've had one baby, be thankful. And that's not helpful to a woman who always envisaged she might have 4 children, for example. It's not helpful to someone who is never going to have children now. The treatment's a small price to pay for life. You should be okay about everything it's brought you. You've got a second chance, so change the way you eat or drink or think or exercise or live or work or do all those things. Change your life. And others say, just don't worry about it. Live life now, don't worry about it coming back. Put it all behind you. And I think women feel very frustrated about that because it doesn't get to the experience that they've actually gone through. They know it's well-meaning, they're thankful for that support often, but also it leaves them feeling more lonely because they've had to face a lot of changes when they come to this.
Yeah, well, that's right, and I guess that can be can bring out anger or frustration and
a whole range of emotions. I think that's a really important point, John, because sometimes people don't respond with fears and tears. People respond with anger or frustration or irritability at feeling misunderstood. And when you look from the person's point of view who's been through the breast cancer, they lose a lot of trust in their body, a lot of physical changes that happen. Changes because of early menopause, for example, or weight changes, and I know, Kelly and Rob are going to talk about some of those things later. Fatigue, increased stress, changes to the way the breast looks or your body looks generally. And then fear of the cancer returning is a very difficult thing for many people to face. They don't know, is a headache just a headache? Is an aching back just an aching back? Or should they go to the doctor? Should they find out about what to do with these things? So there's that sort of getting off, over the cancer problem. But
you just remind me of a point that I saw a patient the other day, and you could just, the tension in the room between husband and wife was just palpable. And I brought up side effects of hormonal treatment and vaginal dryness and sometimes reduced libido and suddenly the man stiffened up and you could sort of cut the air with a knife. And I don't know, do you see that in terms of the partner relationships?
Definitely. Often people expect each member of a couple to cope in the same way and to be at the same coping throughout the journey, and you're just not, just like you are in lots of other things you face in life. And often when people finish the end of their journey, I think many partners are sort of, phew, that's great, let's put it behind us, let's move on. And that sort of, getting back into your intimate life, being close to one another, that's sometimes a relief for partners. But for women who've been through this, and they get all the physical changes that happen, and the dryness and the low libido and the lack of energy and all those sorts of things come on, and it's very difficult to feel normal and to resume a lot of that intimate life again. And then that communication stops, and couples that wanted to really pull together at the end of this and get on to enjoy their life suddenly find there's a whole jarring, and they find it difficult to overcome that and don't know how to talk about it.
Yeah, and another situation I had last week or the week before was, a male partner just doing too much, wouldn't leave the woman alone, and trying to fix everything, come to appointments, take notes, find solutions, and she said to me, John, you just won't leave me alone. So is that common? Or
it is, and we're trying to re-find her independence and take back some of the home duties she was doing before, or get back into work life. And there's, and again, as a generalisation, there's a contrast. Some families are you okay? You're feeling all right? Which can be irritating, because I was until you mentioned the cancer, and now I'm not feeling all right. That can be really difficult. But then other families, you look all right, so you must be all right. And so why can't you go back to doing the list of duties that you had?
Back to normal and do everything.
And often people want to reprioritise and say, no, I want to look at my life differently now.
Jenny, do you see patients come to you after all the treatment, maybe in the city or
Oh, very much. And just as Gemma said, I think these are the dynamics that go on for many, many women. And I guess my job as a GP is to listen and to hear them out. And often this is, you know, a stage or part of the journey for them, and sometimes this, you know, has symptoms and signs or red flags for further depression or anxiety or other problems that need to be sorted and supported. So there's very much a role for the GP here to listen and to support, but also to help the couple to try and get through that, with obviously the many options we have, for instance, in terms of supporting side effects as well as looking from the mental health angle.
Rob, should people go walking together at this point? I'll talk about this later, about exercise, but do you think spending time together exercising, or is that...
Oh, certainly, John. I think one of the strongest outcomes that we have, particularly with our group-based exercise, is women getting together with similar problems and similar issues. They get the benefit of the exercise, but they can discuss their problems together. They can go for a cappuccino afterwards. But also I think it's a great time for you to spend some quality time with your partner in something which is beneficial for both of you physically, but also there's great mental benefits in terms of the relaxation and reduction in stress and anxiety that goes with that.
Jude, any thoughts from your side of the fence with breast care nursing? And do you get a lot of calls at this point after treatment?
Often after treatment's completed, I try to call the woman and just check how they're feeling. Often ask about sexuality, body image, and offer counselling. If it sounds as though the woman might need some counselling, referral. I do tend to encourage exercise. It's important.
Okay. Look, there was a question from Heather that we got during the week, and it's about coping with... she says, Heather says, I know that I do the self-massage on my left arm and breasts, and I will reduce the lymphedema that I have after lumpectomy and full nodal surgery I had in September 2008. However, I cannot bring myself to do it because my fear of finding another lump! ! So it just seems to be getting harder to deal with the psychological fear of recurrence. So I might ask Gemma, any strategies for Heather and other women who obviously feel this all the time?
Yeah, people do feel this all the time, and a certain amount of health anxiety and being frightened of the cancer coming back, although it might not feel normal to that person themselves, is really, really normal. And often that does reduce a bit over time, particularly when those first anniversaries of the follow-ups have happened. But I think there are a few things that women can really do to try and help themselves, and I'll outline some of those things. But I think it's important to keep in mind that it's not a checklist. It's things that you have to do, or things that you can consider doing that might might help the person individually. So it's kind of ideas really to use as a springboard to think about. So some of those things are, first of all, giving yourself some things to try, giving yourself time to adjust. Not expecting that this is all going to happen overnight. It takes time to adjust physically, of course, and it really takes time to adjust emotionally, to all this. And one of the things that's important is to be honest about your feelings. So to reach out to other people, whether that's a friend, a partner, a support group, your breast care nurse, your GP, someone like me, but reach out to someone, because I find many people, when they start to talk about their fears, particularly to others who've been through it, find out that their fears aren't as unusual as they thought. Other people really share them, and I think it reduces that feeling of being alone in a crowd. It's really important to understand who and why you have particular follow-up, and I know we're going to talk on that a bit later. And so who you go to. If you do have symptoms or concerns, what you do, where you go to, who you ask for help. Nurturing your body's important, and both Kelly and Rob will talk about that, but nurturing your mind's important too. Doing stuff you enjoy, even if it's something very, very little, but you do something that you enjoy every day that brings you pleasure, and grasping those kind of, moments, I suppose, that's really important. There's other techniques, mindfulness meditation, might talk about that a little bit later, but ways of actually savouring your life, I suppose. Many people are in a limbo because they're too frightened to live and they're too frightened to die. And I read that on a survivorship website, and I thought that really encapsulates it for a lot of people. And so many people are frightened to die because they're not living the life they want to lead. So actually thinking about what's important in your life, think about your values, what kind of mum or grandmother, employee, wife, sister, where do you want to live in your life, what do you want to do, getting those values and making goals and plans, not to be frightened of plans. That's a really important thing to grab hold of, I think. And in all of that, when you're trying to get information, make plans, live a life that matters to you, watch your thinking, because our thinking runs away with us.
Yes.
And we catastrophise things, and sometimes writing down your thinking, talking it through are really helpful, and not taking your thoughts so seriously. Just because you think something doesn't mean it's true.
Okay.
Just because you think you might not be okay with this, it doesn't mean that that's going to happen.
Okay, well, thanks for that. And I will come back to some of those techniques you mentioned. And I know for any GPs out there or health professionals, you have written a book about different strategies. I can't recall what the book was called and when it was published a couple of years ago.
It was published in 2008, and it's called The Psychosocial Care of Cancer Patients, a Health Professional's Guide for What to Say and Do. Okay. So it's actually, talks about a lot of these particular strategies and common concerns that happen right throughout the cancer journey, including the survivorship phase. It's available through Osmed online. But
back to Jude, you can't do it all. There must be groups out there or websites. What do you tell your patients?
I do tell the patients there's lots of support out there for women who have had breast cancer. There are various support groups in our area of Albury-Wodonga. We have support groups specifically for breast cancer. We've just formed a support group specifically for women under 45 years. And we have groups like the Dragon Boats who are exercising, and they're not literally a support group, but they're a wonderful support to anyone who's had breast cancer. We're able to refer people to other services such as counselling or financial help or social work. And there are lots of resources. The Cancer Council Victoria often has internet support groups available for short periods of 6 to 8 weeks. And women have found them very useful. There's also lots of other resources, such as your book, John, that's very informative for women, and women have told me they've appreciated it.
That was, yes, well, thanks for that. And I guess, Jenny, I just want to go back to you and say, what are the special challenges from your perspective?
Now, I have to say from the beginning, there's not a one-size-fits-all. Some people have very good access to both diagnostic and treatment facilities, and some other people have much poorer access. So I guess talking about it quite generally, the issues that women face are not only trying to get to treatment, but also the impacts of that on themselves and their families. So if you're living in a regional or rural area and are contemplating surgery and then a period of probably 6 weeks away with radiotherapy and then an indeterminate amount of time with chemo, which may or may not be in your local area, then you can see that's a fair mountain to climb. So not only is that a mountain to climb, but the sort of financial issues and the sort of, I guess, the dislocation to yourself and to your family is very significant. And I think we need to be extremely mindful of that and incredibly supportive to women who have to make often quite difficult choices when they weigh all that up.
So the statistics show that more women in the country have mastectomy because of that. Is that?
And certainly that's something that my patients anecdotally say to me, is that they make that choice. They make that choice that if that is often a way of trading off radiotherapy, then that's the reason that they will make that choice. And I think, as I said, we need to be really mindful of that. That's not to say that there's not extremely good care for women in our regional and rural centres. And as I said, depending on where you live, you may have access to visiting oncology, for instance, or treatment services, you know, within a reasonable distance.
Yeah. What about plastic surgery and going for reconstruction? I presume the take-up rate for that would be, again, a bit lower in the country.
I would suspect, anecdotally, just going on my own patients' experience, much lower. I do have women who make the effort. Often they plan for it. It takes 2 to 3 years to plan for it, both in terms of having less on their plates, you know, being able to get children sorted, etc. But also sometimes there's quite a significant financial cost in some of that. And I've got women who will save for 12 months in order to access reconstruction, for instance.
Yes, yes. And I guess resources, you mentioned some of those resources. What about transport and that type of thing?
Transport's often a big issue for women in rural and regional areas, and in our particular area we sit right on the border, and we have Victorian Transport Assistance Scheme and New South Wales Transport Assistance Scheme, and of course they have different criteria for assistance, but it is available and it does help a little bit. There's also often huge financial out-of-pocket expenses for women living in rural and regional areas. For instance, we have a private radiation oncology unit, which is fantastic because the women actually can stay in the area and have the support of their family and friends, but they have out-of-pocket expenses. So we can refer on to get assistance with the financial side of things.
Okay. Rob, just as an aside, does it matter country or city in terms of exercise? I mean, fresh air, open spaces versus availability of gyms or...
John, I think you're only limited by your imagination, to be honest. There's obviously a lot of great opportunities in the country as well, but in terms of, you know, exercise clinics and access in particular to exercise physiologists, physiotherapists, OTs, there's a greater concentration in the city, but there's no reason at all why someone in a rural or remote area can't engage in a very, very effective exercise program which they'll quite enjoy. There are a lot of resources on the internet. There's books available for home-based exercise programs, and they've also been shown in a number of studies to be very, very effective as well.
Okay. Jenny, what should women do for follow-up?
Well, that's a very good question, John, and again I couch this in it will depend a bit on the relationship and the arrangements with your oncology service. But in the main, oncology services will look after women certainly for the first 2 years post-treatment, but after that it's usually a negotiation with the GP so that there is absolutely no reason why shared care cannot occur really from any point post-acute treatment for breast cancer. And there are some very helpful standardised guidelines which tell us what should be done at various times post-treatment. And they're simplistically, if you like, that say in the first 1 to 2 years following breast cancer, that you should be seen every 3 to 6 months, opportunity for GP or oncologist or key health professional to take a history, to examine you. And certainly mammography is recommended 3 to 6 or 6 monthly, and then 12 monthly from the 2 year point on. So you need a relationship with someone. Many GPs are extremely competent and able to provide that care, and obviously the GP sees you as a whole person. So your breast cancer is part of the baggage you carry, but we're all fallible human beings with our other chronic diseases and our other issues. So your general practitioner is in a good position to see you, I guess, as part, to see your breast cancer as part of what you're bringing. And certainly, as I mentioned earlier, we're obviously on the lookout for the things that aren't going so well. So whether that's treatment side effects or whether that's mental health issues, you know, they're the sorts of things that we keep in mind. And we do have some quite good item numbers in our armoury that we can use if things aren't going so well. So, for instance, there's the enhanced primary care item numbers, which, considering that I regard cancer as a chronic disease, that if you've had an issue for more than 6 months, which obviously is quite common in the case of breast cancer, and if you need the assistance of 2 or more health professionals, that we can use that program to identify assistance for you, perhaps referrals to dietitians, exercise physiologists or similar.
Okay, well thanks for that. There are a couple of questions relevant to this segment, and one is, should I have regular blood tests? I'm not sure if you should comment on that, Jenny.
Oh, perhaps if I start and then hand back to you. But, obviously, when you're actively under treatment, then regular blood tests are imperative.
We're talking about.
But post-treatment, I mean, my experience is that with on certain of the medications, certainly regular blood tests, you know, and certainly I would be taking the advice of the oncologist with a regimen along that line.
So basically, we often do some blood tests, look at vitamin D and sometimes thyroid, and just a regular blood test your GP might order. But there's no blood test that we do to monitor whether breast cancer comes back or not, and there's no magic blood test, unfortunately. And you know, really, my view is get on with your life and don't have a lot of tests, because tests don't really make a lot of difference. We've given you your treatment, we've given all the insurance therapy, and it's time to be positive and get on without having lots of tests and waiting rooms and injections and needles, and most people have had enough of them by this point. There's another question here, which was exercise during radiotherapy treatment. Now we are concentrating after treatment, but we should just any contraindication to exercise during radiotherapy? I can't see any as a radiation doctor, but
no, John. There's been a wide range of clinical studies and research completed, and exercise seems to have application immediately post-diagnosis, prior to surgery. There seems to be good benefit there if we can get them a little bit fitter and perhaps even lose a bit of body fat prior to surgery. But certainly during treatment, there's been several good studies indicating that it certainly reduces the amount of fatigue that the patient experiences. So I do believe there's good application during radiation therapy and chemotherapy, but of course we have to work within the fatigue cycles that the person's experiencing. But we do know that choosing a total rest strategy is counterproductive, and any amount of exercise that they can do will reduce their symptom experience. And actually, some of the really solid research, particularly around chemotherapy, is showing greater dose tolerance. So this is really very, very important, that if someone is completing exercise and is fitter, they can actually tolerate higher dosages, and so the outcome in terms of cancer survival is greatly improved with that.
Okay, thanks for that, and thanks, Carol, for that question. And Carol also asked about when. I guess that depends on your own schedule when dropping off kids or going to work, or fitting it around your own schedule. But there's no right or wrong about that. But I think the take-home message is do some rather than none. And I'll just ask Kelly. We've got a question from Danny who says, should you not eat soy products if you have a hormone-sensitive cancer?
Yeah, that's a common question.
Very common, isn't it?
Generally, the advice is soy products, as in foods, are okay to eat if you've had breast cancer, so whether it's estrogen receptor positive or estrogen receptor negative. I suppose the thoughts are that estrogens or the phytoestrogens in the soy products might interact with the tamoxifen or medications women are taking. So foods seem to be fine. It's more, I wouldn't recommend supplements or the phytoestrogen supplements.
Okay, thank you. Best advice you've received. I'll just do some of the advice we've got from our audience. Maggie from Wangaratta, Encore program was most beneficial, and support group has been terrific. And now the Encore's the exercise program in the water, isn't it? Is that right?
Yes.
And it's a 6-week program, and they do a fantastic program. And Judy from Swan Hill, accept the new normal, enjoy your new life as much as you can. And Suzanne says, leave the hospital and put the breast cancer well behind you and get back involved with my family and friends. And Helen from Port Lincoln, go home and start the rest of your life. And good advice from Mandy from Tasmania, take each day one day at a time, with a smile when able. And the Breast Cancer Network Australia, fabulous organisation, is all about support and empowerment, and you know, have a look at their website. You know, we haven't really concentrated on diet too much, but I know every time I see a patient after their treatment, they want advice about diet and exercise, and many women are concerned about gaining weight after treatment from chemotherapy and hormonal treatments. And what advice do you give women about diet? You know, what's the bottom line?
Well, I guess it varies depending on the questions women have. Some people come from a very healthy standpoint, so they'll have a lot of questions about the foods they ate, whether something they particularly ate caused their cancer, and they might have a list of supplements asking whether, you know, each particular one will prevent their cancer coming back. And then there might be someone that maybe making small changes to their diet would be the best thing they can do, so it might not be achievable to say to them, go on this low-fat, high-fibre diet, when, you know, they may get quite a big benefit out of just modifying their diet slightly. So, you know, it might be just concentrating on a couple of things like increasing their vegetable intake, or, you know, cutting down to 1 drink a day rather than 2.
Vitamins are always in the press. 1 week they're good for you, 1 week they're not good for you.
Yeah, there's quite a bit of research going now with the use of vitamins and breast cancer. We don't think that vitamins can replace what's in a diet. What's in foods are going to be more beneficial the way they interact with each other. So I suppose where supplements can be beneficial is if they replace nutrients that are lacking in the diet. So in that way it may not cure their cancer or prevent their cancer coming back, but it might just replace a deficiency. So a good example, you mentioned vitamin D, iron might be another example. So it'd be worthwhile looking at their diet and seeing if there's any chance of nutrient deficiencies. As far as vitamins and cancer recurrence, there are a couple of studies looking at multivitamins and show that there are improvements in survival in breast cancer patients. Now, whether that's because women that take multivitamins might be healthier to start with, or they had diets that were lacking in certain nutrients that, you know, brought them up to their ideal levels.
Okay. A lot of my patients ask me, what foods should I avoid, and how do you answer that question?
I suppose the first thing I'd say is there's nothing you should downright avoid. You should be able to enjoy everything to a small degree. If your general diet's based on lots of fresh fruit and vegetables, whole grain breads and cereals, you know, small amounts of lean protein, plenty of fish during the week, then it's okay to have a glass of wine or, you know, a takeaway here and there. It's not going to make the cancer come back. I think some of the strongest evidence we've got with recurrence is achieving a healthy weight. So probably rather than feeling guilty or worrying about particular parts of their diet, I think they'd be better off concentrating on an overall healthy lifestyle and trying to just get that weight down as close as they can to their ideal body weight.
Is it true that fizzy drinks and you know, that sort of thing can affect vitamin D levels, or you know, should we be avoiding sugars, or?
I guess there's a lot of myths and fallacies about diet and cancer. I often get asked by patients whether they should cut meat out or dairy or sugar's a good one. Generally, sugar is not going to cause their cancer or make it come back, although there is some evidence that high GI foods can raise insulin levels, and so insulin's a tumour-promoting type of hormone. So as over a long period of time, if someone's eating a lot of high GI foods, which includes sugar, but not only sugar, it's also like the white breads and the refined starches, there's a chance for the high insulin levels, which might in turn increase estrogen and increase the risk of their cancer of recurrence. But I don't think we should put the blame on sugar as such.
Right. And Jenny, I guess that's good for your normal health, isn't it, not to have too much high...
Absolutely, and again, I think this is where we look at the breast cancer as part of the person, and the person may well have the baggage of some other chronic diseases. So I'm a great believer in everything in moderation. You know, a little bit of chocolate here and there never went astray.
Okay. What about a little bit of alcohol?
I think so.
I think so. Okay, all right. Bit of McDonald's, KFC?
Well, again, I thought Kelly put it very neatly. You know, if it's on the background of a good diet and common sense and exercise, then those things are just fine.
But try to, everything in moderation. And Rob, any advice you give your patient in your wellness centre in terms of diet or...?
Well, we try and get them to work towards a normal body weight. As Kelly's pointed out, having excessive body fat increases estrogen levels, and that's cancer promoting in terms of breast cancer responsive. So exercise does reduce insulin and does reduce estrogen as well. So I think an integrative approach is the most important one, where exercise and diet are intimately coordinated and in a team, which includes the GP and the psychologist as well, to help with their behaviour change. But I think when you've got that team of exercise physiologist, dietitian, actually making those and supporting the person in that lifestyle change to get down to a more healthy weight. You cannot afford to have your body fat increase post a breast cancer diagnosis because of the risk of recurrence due to estrogen.
So, Kelly, weight gain after treatment, basically you're saying healthy diet, reduce all these foods, charred meats and fatty foods, everything in moderation. One of my patients said to me recently, she was a health exercise instructor. She does 15 hours a week, skinny as anything. And she said to me, John, it's 80% diet and 20% exercise. Now, what do you think, Rob and Kelly? I mean, is it what we put in our mouths or what we...
I think I agree with Kelly. It's a balance of all those things, and you can't leave the mind. You can't separate the mind from the body. You have to have all those things working together and in balance. But there's a lot of important components in terms of the diet, but also in terms of exercise. In terms of increasing muscle mass is very, very important, and increasing your cardiorespiratory fitness is very protective also. That can only be done through exercise. But if you don't have the correct nutrition, the correct building blocks, then it's not going to be as effective. So it has to be integrative.
Gemma, I mean, you know, people feel down. They feel, you know, need a fix of chocolate or something. I mean,
they feel overwhelmed.
They feel overwhelmed. I mean, it's easy for these guys to say that. But, I mean, what's the real?
Actually, coming back to what Rob said in the beginning, I think is really important about making the small change. Doing something's better than doing nothing. And I think many people feel as if there are lots of guidelines that they should be following in all sorts of aspects of life, and you know, get overwhelmed with the weight of guidelines and therefore do nothing at all, and then live in guilt. And I think just actually starting, realising that, you know, look, we have to polish various bits of us, you know, in our lives, and that all takes time. And if you go for a walk today, that's better than going for no walk today. And gradually those things build. But actually using exercise and diet as another stick to beat yourself with is actually not a very helpful thing to do. But actually seeing it as an investment in yourself, an investment in your future for you and your family, that's a completely different way of looking at it.
And it's something you can do for yourself.
Something you can do.
You can spend time with your partner, time with yourself.
Time to think. And yeah, and many people say to me, I don't want to live the life I was leading before, but I want to make, you know, I want to be different. And actually making some of these subtle changes can give a woman more sense of, you know, empower her to think that she's actually looking after herself a bit better than perhaps she might have done before.
Okay, so it's a wake-up call. It's time to invest in yourself and perhaps be a bit selfish and give more time to yourself rather than everybody else, I suppose.
That's right, and there are other times that happens in our lives as well, not just cancer, but it's a perfect time to use it as a catalyst, really.
Okay. I just want to go to vitamin D, because I know, Kelly, we've got a vitamin D research program at Westmead, and you're about to publish your first paper on vitamin D and sun levels and so on. Can you just tell us a little bit about that paper that's going to be published in the Medical Journal of Australia soon?
Okay, well, maybe first of all pointing out why vitamin D is important, because there's some evidence that women who have adequate vitamin D levels when they're diagnosed actually do better in terms of survival. But the trick is getting enough vitamin D without increasing your risk of skin cancer, because sunlight's our major source. Foods has some vitamin D, but to a lesser degree, so the idea would be to try and get our sunlight recommendations from vitamin D. So in the paper we're about to publish, we looked at how much time you need to go out in the sun to meet your vitamin D requirements without increasing the risk of skin cancer. So trying to keep in mind those Cancer Council guidelines to go out when the UV's under 3. So
vitamin D in our diet?
So a few foods contain vitamin D. It's quite difficult to achieve. It's oily fish, very small amount in meat and eggs. There's fortified foods in Australia, so we've got some milks. You'd have to look at the label and see whether it actually contains vitamin D. There's also a few cheeses and yogurts. But generally, you don't get a lot of vitamin D out of foods. For instance, we're suggesting you might need to be having about 2,000 international units for the prevention of chronic disease, which is quite a bit higher than the recommendations for bone health. So to get that much vitamin D would be quite difficult. So we're suggesting people could go and have a blood test, and if their vitamin D levels are low, perhaps they might try and get out in the sun a bit more, or consider a supplement.
Okay. All right, and I guess, Rob, vitamin D is so important in bones, and exercise is important for your bones, and when we have people on aromatase inhibitors, we do vitamin D levels, parathyroid levels. We talk about vitamin D replacement and calcium replacement. But I guess weight-bearing exercise. What is weight-bearing exercise?
Weight-bearing exercise, John, is anything ranging from walking to jogging to skipping, those sort of activities. In terms of stimulating bone, though, it really has to be, you know, rather high impact, and that's going to sound a little bit scary, but there's a lot of research that has been completed showing that, for example, just light walking doesn't really benefit the bones in terms of maintaining their density. It's not a strong enough stimulus. And so under a controlled environment, preferably monitored by an allied health professional like an exercise physiologist, there are programs out there involving activities like skipping and bounding and jumping, which are actually quite beneficial and have been shown to actually cause the accrual of bone. But the vitamin D is a very interesting story because it's not only important for retaining bone, but also good research showing it's also necessary for muscle and muscle growth and maintenance of strength. So the vitamin D is an important one.
Yes, yes, and I think it's often overlooked, and I think you know, talk to your GP about getting a vitamin D level. And Rob, exercise. What's the evidence for physical exercise?
Oh, John, it goes right across the stages of the disease. I know we're talking about survivorship here and post-treatment, but particularly with breast cancer and colon cancer, there's now strong evidence that exercise, physical activity has a strong protective effect and reduces incidence. We're using it a lot in our clinic and other places throughout Australia. Exercise physiologists working within an integrative team to prescribe exercise for women with breast cancer to help them through their treatment. We know that it reduces the side effects, in particular reduces fat gain, but also I think the improvements in terms of the psychological well-being of the patient are also very, very important. And probably one of the strongest messages to come out of the research is that looking at all these physical changes and psychological changes, some of the most consistent in the research has been the reduction in anxiety and depression amongst women with breast cancer. In fact, all cancer groups that have been examined. But I think the most exciting evidence to date is from a series of studies. The landmark study is by Holmes, looking at the nurses cohort study, massive study in the US, tracking women with breast cancer. And they actually determined a 50 to 60% reduction in mortality from those women who were quite physically active versus those that were sedentary. So there we're seeing that it has a very strong effect in terms of actually your chances of surviving your cancer.
Right. And I guess, Jenny, it's good for cardiovascular disease.
Absolutely, and again, seeing the patient as part of the, you know, as their cancer as part of themselves, obviously the benefits in terms of cardiovascular and other disease. But I'm just wondering, Rob, what sort of, you know, is there, in the exercise prescription, is there one particular sort of exercise that one should be doing?
I think with breast cancer, probably the most important thing is to get body fat levels down to a more normal range. That's probably the critical key. In other cancers, it's to maintain muscle mass and bone mass, but particularly in breast cancer, it's to get within normal body fat levels. And so aerobic exercise is probably going to be the most effective. It has to be combined with diet and some caloric restriction to bring down the body fat levels. And new research shows that intermittent type exercise, where you have a sort of bit of a sprint and then a recovery and then a sprint, that type of exercise seems to have a much stronger effect in terms of fat loss. And so that's probably our best bet in terms of breast cancer. Resistance training, though, is still critical. We all have to do resistance training throughout our lives. As I say, there's been two very, very important statements which have come out. One in the US, released through the American College of Sports Medicine, on exercise guidelines for cancer patients, and there is a section in there on breast cancer. And the other statement, which was released in 2009, which was the Exercise Sports Science Australia. So that's the association that produced a position statement on exercise for cancer patients. And the recommendation in that is to accumulate at least 150 minutes of aerobic or cardiorespiratory exercise each week at a moderate intensity. So that's 5 times a week by 30 minutes. It's not a big ask. But also to do between 1 and 3 sessions of resistance training. And there's really solid research now supporting that. And that resistance exercise has to involve lifting weights or lifting some form of resistance that you work against to get the benefits for the bones and the muscles. But also the resistance exercise has a very powerful effect on the endocrine system. And in particular, it suppresses insulin, it reduces the level of estrogen in the body, lifts testosterone. So they're very, very important positive effects for a person who's recovering from breast cancer.
So you're saying it may help with libido as well? You're saying testosterone or androgen levels in women as well?
Absolutely, John, because both in men and women, and even in quite older women, certain types of exercise, particularly resistance training or any higher intensity exercise, causes a spike in testosterone, and that's testosterone is great for the brain. It slows cognitive decline, but it's also great for libido.
Right. When you say resistance training, just give us how much should they start with, and how many lifts should they do, and what's a take-home message?
Sure. Look, I think where possible, it would be good if they could get to an exercise physiologist or a physiotherapist to actually get assessed and get a prescribed program for them.
Okay.
But the general guidelines are applicable, and the important thing in terms of resistance training is that the weight or resistance should be such that you can only lift it or move it 6 to 12 times.
Okay.
If you can move it more than 12 times, that resistance is not sufficient. You need to give those weights to your husband, and you go out and buy some heavier ones.
Okay. So a dozen times is a key message?
A dozen times or less.
Yeah, or less.
We, in a controlled environment in our exercise clinic, we have women with breast cancer performing sets of exercise where they can only lift the weight 6 times.
Yeah.
And that intensity would seem quite high, but we have, in many, many thousands of patients that we've worked with, we've had no incidents with that. All of the research, both here and overseas, suggests that resistance training is very well tolerated by cancer patients with very few adverse events. And so it's important to have that intensity, otherwise we don't get the hormonal response that we need to increase the survivorship and to overcome all the range of other chronic disease issues that we face. We have a bit of a saying in our clinic is, sure you've got cancer, okay, but all the other chronic disease processes continue to march on. They don't care that you have cancer.
Yes.
And that's why we see that a large proportion of our cancer patients die of heart attack, stroke, diabetes. They don't die of their cancer.
Yes.
And the worst thing you can do is adopt a rest strategy, because that will greatly accelerate the chronic disease processes.
Okay. And what about your lower limbs, knee bends, or building up muscles in your thighs, or?
Total body workouts is important, but particularly in terms of testosterone, because I know you're particularly interested in that testosterone libido story, John. Large muscle groups, so exercises like squat, and it doesn't require a lot of equipment. It could just be body weight squats against the wall, and then the introduction of some hand weights or even jugs of water or any type of weight to increase the resistance.
Okay.
Frozen milk bottles.
Frozen milk bottles.
You still have milk bottles?
That's the country, with the handles, the 2-litre milk bottles, you can just freeze
plastic ones, yes. Oh, good idea.
And then you can drink the milk, it's good for your bones.
Well, I guess I didn't think of that.
Okay. Look, I might just talk about the joints as well, and a lot of women on... we have had a lot of questions about aromatase inhibitors and how long women should take hormone treatments. I want to digress for a minute, but the problem with some of these drugs is it reduces estrogen or blocks estrogen, and estrogen seems to be a natural lubricant of joints, and people start getting muscle aches and pains or joint pains, and I'm just not sure if there's any data on exercise and joints at all, and joint stiffness in the morning. Or
there's not a lot of research, I've got to admit, but if we have a look at some other very similar conditions such as osteoarthritis, we know that in particular resistance exercise is well tolerated. Aerobic type exercise with a lot of repetitive movement is not well tolerated by women who are on these aromatase inhibitors. So what we do in our particular clinic is prescribe resistance training within their pain levels and their tolerance. Quite often we're seeing that only certain joints are affected, and so we design a program around working the other muscle groups as much as possible, John. But all the evidence that we see anecdotally is that resistance exercise has good benefit for those patients.
There's a question here from Cheryl. How many years after diagnosis can you start to relax it? You may be over the highest chance for recurrence. Maybe I'll answer that. In my experience, certainly the first year after treatment, the second year is quite stressful. People, every muscle ache and pain is cancer until proven otherwise. The evidence shows that the risks are highest in the first 5 years, and that's why we talk about 5 years. Obviously you need to be, to use that phrase, alert but not alarmed after 5 years, but most recurrences occur in the first 5 years. And certainly if you get to 10 years, if data shows you've got like a 98% chance of getting to 20 years. So the reality is, I remember a lovely lady I used to follow up, and she came into me once and said, "John, I've got all these aches and pains everywhere," and I said, what did you do on the weekend? And she goes, "Oh, well, I did cut the tree down for the firewood," and you think, well, that's what's caused all your pain. I thought if I had to cut down a tree, I'd be in bed for a week. So think about what you did on the weekend. I always talk about the Panadol ad on the TV, that take some Panadol, have a rest. If pain persists, see your doctor. And cancer pain tends to not go away. So that's Cheryl's question. And Cheryl, again, I'm not sure if it's the same Cheryl, is what's the best practice for hormone-sensitive cancers? I've just spent 6 months in Oxford on a sabbatical, and I was totally frustrated with the UK approach, because everybody who was ER positive just got this one drug, Femara. It said Femara from everybody. And I spoke to one of the surgeons and said, "Look, I think you guys are giving too much aromatase inhibitors." I said, "They do cause side effects." "No, they don't." I said, they cause vaginal dryness. I've seen patients who've lost their orgasm totally. I've seen loss of libido. Our patients don't get that. And I then said to the surgeon, "Do you ever ask your patients?" Well, no, I don't ask my patients. So the reality is that some of these drugs can cause side effects, and we've got 35 years of, I think, tamoxifen, very safe drug, gives the same survival rate for breast cancer as aromatase inhibitors. There is some evidence that there's a little graphic, I think, from my book, Breast Cancer Taking Control, which looked at all the 5 different trials. I'm not sure if we can get that up, but basically all these trials, one showed what's 5 years, after 5 years of tamoxifen, should I have 5 more years of Femara? The second trial looked at 2 to 3 years of tamoxifen, then aromatase inhibitor like Arimidex or Femara or Aromacin. The next trial looked at one or the other, and so on. Don't look at the detail, but most of these studies showed a slight improvement in delaying recurrence from an aromatase inhibitor. And the latest results, which were about a year ago now, where they compared all these studies, found that the improvement was about 3%. So 100 women would have to take an aromatase inhibitor over tamoxifen, and may delay recurrence in 3. And most of that delay may be a cancer in the other breast or something happening in the same breast. So I know Professor Wilkin and I have always said, if your bones are bad, or if your breast cancer is good, tamoxifen is probably okay. If your bones, and we said this in our forum last year, if you want to go back to the tapes, if your bones are good and your breast cancer is perhaps less good, maybe there's lymph nodes involved or it's bigger cancer, we sometimes use the aromatase inhibitor because the added benefit is more. But the important thing is don't be too hard on yourself. I had one lady come in basically in a walking frame, and I said, "What's wrong?" She said, "I've just been immobilised ever since I've been on an aromatase inhibitor." And I said, "Just stop it. The benefit, there's no survival benefit. The delay in recurrence, you can't live your life like that. So quality of life is really, really important, not just perceived quantity of life or delays." So I'm not sure if anybody, Jen, if you've got any messages there, but...
I'd just like to concur with that again, try and look at the whole picture.
Yeah.
And certainly, as you're describing it, you know, it's perfectly reasonable to make a choice for another drug when it's impacting on you as severely as for that woman.
And for the doctors out there, ask your patients, don't be like that surgeon in the UK. I often ask my patients, I often say something like, look, a lot of my patients get vaginal dryness, or they may get pain of intercourse. Introduce the topic that way maybe. And I sometimes say even reduce sex drive. And, you know, when you say that, it does open up a can of worms. Sometimes it can delay your consultation. And you know, I've had ladies in tears, it's, you know, because they're thankful that someone's raised it. It's suddenly the issue's on the table, and we can then say, well, let's look at tamoxifen rather than persisting with an aromatase inhibitor in that setting. Or in a woman who's getting a lot of vaginal discharge from tamoxifen, maybe we look at an aromatase inhibitor. But I'm not sure, Gemma, sexuality, it's a hard ask to a busy clinic, lots of patients in the waiting room. It's such an important issue.
It's a huge issue, and it's one that a lot of the evidence shows that if the health professional doesn't bring it up, that the person won't bring it up themselves. So it is useful because it can be an uncomfortable topic, but just get used to a phrase that works. You know, what about the intimate side of your life? Or this affects a lot of women in some ways, and you know, vaginal dryness is one of them. You know, have you noticed those kinds of changes? And just introduce the topic and get used to doing that yourself, and then people will tell you what's going on. I think if your patients never talk about their sex lives at all to you, that's probably something in your communication style.
Yeah, so, you know, look, it's important to raise it and then seek advice and
just like anything else as well, if you're not confident to manage it as a health professional, refer on as you would for anything else, you know, that you wouldn't be managing as a health professional.
Where do you refer on to, you know, for sexual problems?
I often discuss them, and I often bring it up saying that there's been recent information that about 85% of women who have had breast cancer, have had a breast cancer diagnosis, have sexuality issues. So with that many people having a problem, then it's often quite easy to bring it up, and it just seems to flow. People talk.
Good.
John, in the last week I was on the phone to an oncologist, pleading with the oncologist to see if we couldn't sort out something better with someone's treatment regime. This is a 36-year-old woman who was, you know, experiencing significant issues from vaginal dryness, and I couldn't believe that we were going to leave her to leave the rest of her life in that situation. So it only took a phone call to the oncologist to raise the issue and then look at helping her alleviate some of those issues.
And fantastic, as you know, as a GP to take the time to chase the oncologist and do that. Look, there are some more questions and comments. Pam from Canberra, thank you for reminding us about yoga. Very important. We've got a yoga program at our Breast Cancer Institute. Has been shown to help. I think there's Sally. I'm not sure where you're from, Sally, but Tai Chi was a great way for you to get back into exercise after chemotherapy, knocked her capacity to do exercise. So I think that's a way of, I guess, getting some control back, and she's gone beyond the beginner's level. And there's a comment here from Mandy from Tasmania. What about those women who absolute hate, in capital letters, exercise? From days in skills and those ghastly sports sessions. What can be done to tempt them into the fun of exercise? I guess yoga, Tai Chi, any other ideas quickly?
A wee, actually, and I often suggest that to people. It's fun. A wee, you know, the wee fit.
A wee, okay.
It's fun, couples do it together, you can compete, it's kind of exercise without really exercising, and I'd be interested to see if you think there's any benefit, but it certainly gets people moving again and associating moving with fun, actually.
Now, not all of us know what a wee is, but I believe it's some sort of electronic gadget.
And it's being used in a lot of studies actually to implement exercise amongst a whole range of patient populations. I think that one of my take-home messages is that to do nothing, total rest strategy is the worst possible thing you can do. Anything you take up, it can be line dancing, yoga, Tai Chi, it doesn't really matter. There is probably an optimal level of exercise where you get the best benefit, but there's a big range in that. The worst thing you can do is adopt a rest strategy. Anything that you can take up in terms of physical activity would be beneficial.
Yeah, well, that's a great idea. Maybe even parking the car further away from your workplace
Yeah,
or
incidental exercise.
but dancing's a great idea. I know a whole bunch of line dancers, I'm not sure if they're listening tonight, come to our breast cancer breakfast every October. Kelly, the best way to advise various cultures that have strong beliefs that certain foods should be omitted, i.e. seafood. So have you come across that? In Western Sydney we've got a lot of different cultures, I'm not sure.
Yeah, so they're saying that they should be avoiding them? Is that the question?
Presumably some cultures say you shouldn't have seafood.
Okay, in the thought that it might cause the cancer to come back.
I'm not sure.
I guess looking at different food groups, like I've mentioned, there's no particular food group that's going to cause cancer. I think something that's important to keep in mind with seafood is it is a really good source of omega-3s and it's a good lean protein source.
Okay.
So I think any diet that's going to cut a major food group out of their eating patterns not worth following. They're likely to lead to nutrient deficiencies, and then that might have implications in terms of not having enough energy for just growth and repair and exercise.
What about olive oil or something like that? Can you replace seafood with something else or not?
Well,
really?
I suppose a plant-based diet or a non-meat diet, you can still achieve adequate nutrition. So if you are cutting seafood out totally because of beliefs that that there's no way you want to include that, there are other ways to get adequate protein.
Maybe speak to your nutritionist and
yeah,
get some advice.
I suppose if you want specific advice on your diet, it's worthwhile either seeing a dietitian or
Okay, Maggie asked a good question here. I don't know anyone who's had a vitamin D level who was in the normal range. Are the levels correct? And now, Kelly, we've been taking blood samples from hundreds of women with breast cancer. Just without giving away all your results, what's the deficiency range that we're finding?
It's very, very high, particularly in winter. I think most women were in the sort of 20s or 30s.
Yeah.
In summer, you get some women that are up around the right range, but then some women are still deficient. But I guess there's a question about what is the right range. I know the blood guidelines would say 50 millimole is the adequate level, but I think for cancer prevention we're suggesting it might be up around 70 or so.
Yeah. So it's up around 70, and how much supplementation? Someone's asking here, Jenny's asking, is it 1,000 international units or 2,000? I guess that depends on your level a bit.
Yeah, I guess a lot of factors also affect your level. Being overweight can significantly reduce your vitamin D. I was mentioning before about sunlight. It is much easier to get enough vitamin D from the sun. So, for instance, if you were to go out in the sun for 10 minutes in the middle of the day, even though that's not quite advisable, you'd get about 20,000 international units with the whole body exposed. Now, to get that much out of supplementation would be quite difficult. But with supplementation, generally we're advising around about between 1,000 and 2,000, but it might be worthwhile having blood test and seeing what your level is to get it back up to that 70 mark.
I had a lady from Sri Lanka the other day and her level was 20, and I ended up sending her to an endocrinologist who did a whole lot of tests but put on 2,000 a day.
So for someone with
weeks.
very dark skin, they may not be able to get enough vitamin D from the sun. So,
so that's a risk factor, isn't it?
Yeah.
Okay. A few other questions here. Rachel from Bateman's Bay. Are chemotherapy regimes prescribed the same for patients in rural areas versus teaching hospitals? I guess...
Anecdotally, yes. Certainly the clinical trials seem to come out of right out, so that I've certainly got patients who are on chemotherapy and on clinical trials, so it would strike me as a clinician that rural women are getting the same access to chemotherapy and to the latest regimes as those in metro.
Okay. And I guess the reality is there's no right recipe.
No, that's right.
And I know
it is a recipe.
It's 3 or 4 different oncologists would give slightly different treatments. And we talk often about generations of chemo and levels of intensity, and there's not a lot of difference in them. And sometimes we do tailor them a little bit to, in younger women, use drugs that affect fertility less if you haven't had a baby, or in older women we might use different drugs. We may use different sequencing of drugs from someone from the country, so they have to come every 3 weeks rather than every week and can get home in between cycles. So we've is it possible to have contact from the breast care nurse once treatment is finished? Certainly that's the case in our centre, but I presume McGrath is one of the solutions there. People can ring your office and try to get in touch with the closest nurse, or
They certainly can.
Yeah.
They can check the website to see where their closest McGrath breast care nurse is.
Yeah.
There's also lists of where breast care nurses are available on most of the Cancer Council websites.
okay. And we've got a lot of websites will be on the foundation website later, and including some sites from Rob on the types of exercise you can do, and I presume little videos and so what more specific detail. A quick couple of questions from Gail and Susan about alcohol. Should I stop drinking altogether? I think we've sort of answered that, haven't we? Everything in moderation.
Yeah, I think it's important to be aware that even like 1 drink a day, it does increase risk very slightly. So it's not that we're trying to alarm women, because I think it's more important that they have some things in their diet that they enjoy.
Do you mean for women who don't have breast cancer, or women who do have breast cancer?
Well, for women that don't have breast cancer, actually. For
Yeah.
women that do have breast cancer, there's not a lot of evidence that drinking will have an effect on their recurrence.
Yeah. So look, a glass of Jenny, a glass of red wine's good for you, isn't it? For the
Sounds
heart?
very good for you.
It sounds very good for you. Okay.
You know, and for many women, you know, after a busy day, that's a lovely way to relax with their family. And certainly, I'd be very unkeen to be giving prescriptive advice suggesting that that was not perfectly reasonable.
Thank you. And Sally from South Australia, if I'm worried about treatment side effects, who should I ask? Well, I guess ask your doctor, your breast care nurse, your general practitioner. And remember that a lot of aches and pains are often normal. Your new normal, I think, Gemma, you called it.
But play it by someone. If it is worrying you,
Yeah.
then you know, a burden shared is a burden halved.
Yes, that's very good advice. There's a question here, Gemma, about are survivors more prone to depression? It's a very good question.
It is a very good question. Yeah. Look, actually the things that are a risk factor for depression are more to do with other aspects of your lifestyle, things like number of dependents you have, how much social support you have, whether you've got a previous history of depression, whether a family history of depression, and some other things. It's probably not an easy question just to answer in terms of where you are in the cancer journey, but certainly it's not uncommon for women to become depressed or highly anxious after treatment. And if you feel that way, and if you're thinking this is not normal for you, or you haven't had an experience like this before, you're on some of the hormone therapies which can affect your moods, most certainly. It really is worth talking to somebody, because sometimes those changes can happen slowly and you don't notice them, you don't reach out for help. So normally what we say is if your mood's been down for really a couple of weeks, you're not enjoying things as you used to, you might sleep or appetite might have changed, your libido's low, we've talked about some of that, and you really are losing hope or sight of the future a bit, that's really worth talking. And we usually say talk to the GP first, or reach out to somebody, and the Cancer Council helplines are excellent for this too. They can give really sensible advice on where to turn.
Okay, and I guess there are a few women who do need to see a psychiatrist and get proper treatment for clinical depression
and just
depression.
As Jenny was saying before, the cancer doesn't happen in a vacuum, and so lots of people get depressed anyway, quite apart from the breast cancer, and it really is important to reach out for help.
Okay, just Mandy says, I personally found vaginal dryness was so severe I found it hard to walk! ! Lubricants used regularly helped, and now I'm almost 7 years post-diagnosis treatment, occasionally require lubricant. I must say we had Michael Kreichman who's a world sex expert and women's health expert from California at our last International Breast Cancer Conference, and he's written a book on this topic. And one thing he taught me was I recommend my patients now to use vaginal moisturisation, vulval and vaginal moisturisation with vitamin E or sorbolene or their favourite moisturiser after the shower every day. It's thin skin, it can tear, you can get severe vulvitis. So that's moisturisation as opposed to lubrication, which is water-based lubricants prior to sexual activity, is very important. Now, there's some patients that I also recommend a little bit of vaginal estrogen from time to time, and that's perfectly safe. There's a question from Rachel, who's 33, who wants to know whether she had a mastectomy on the other side. She's had aggressive breast cancer on one side, and my advice at the moment is just to, if there's no lots of family members just to sit tight, let's get this out of the way, get on with, trying to recover both physically and emotionally from this one, and then start talking to your doctors about the other side. There's no evidence that preventative mastectomy improves life expectancy. It can have some psychological benefit, but we certainly do think about it in women who do potentially have the breast cancer gene, and we ask women to see one of the family history clinics right across the country. And in women with the breast cancer gene, remember that Medicare has now funded breast MRI scanning, which is more readily available. Just to finish off, and thank you to our panel once again for your time and your expertise. I'd just like to finish off by asking each one of you just to give our audience a couple of take-home messages, maybe starting with you, Jenny.
Well, I'd just like to say that I think breast cancer is a journey, and I talk to my patients about it being one of the bags that they carry. But they do carry other bags, their family histories, their contexts and all sorts of other things. And I guess just to be really clear that you can set your own goals, and that there are people around, such as GPs, breast care nurses and other health professionals who are really out there to help.
Fantastic.
I'd say be kind to yourself. There's no real formula about how to cope with this emotionally. Everybody is different. Reach out when you need to, but probably most of all, don't be afraid to invest in your future. We all need something to hope for. We all need something to look forward to make us happy, and that's what humans do. So it's no different if you've had breast cancer.
Rob?
Oh, John, I think get out and enjoy life as much as you possibly can, and I think that physical activity is a great way to do that, and it's got so many other health benefits. There's been no evidence whatsoever that physical exercise is dangerous for women with breast cancer or post-breast cancer. Get out, enjoy yourself, get physically active. The worst thing you can possibly do is put yourself in a cocoon and take a rest strategy. That's very, very dangerous.
That's an important message, isn't it? Thanks, Rob. And Kelly, what about from you?
I think it's probably to enjoy a healthy, balanced diet. So it means including a wide variety of foods rather than worrying about what you shouldn't have to prevent your cancer coming back. But particularly with an emphasis on trying to achieve a healthy body weight, because we know that that's a big factor. And lots of the healthy things in fruit and vegetables, so the antioxidants, high fibre diet, low fat diet, but have some foods that you enjoy as well.
Yeah. A little bit of alcohol we said was okay, a little bit of, Jenny, you said a little bit of chocolate at the end of the week is okay. And thank you, Kelly. And Jude, what do you think?
I often talk to women about there being a new normal after breast cancer, and say it might be just having an extra piece of broccoli a week, or it might be a whole new career change or whatever. So I guess basically enjoy life, and if you have any concerns or want any information, contact GPs or breast care nurses or talk to somebody about them.
Look, we are very lucky in Australia. When I was in Oxford, I'm now on the UK committee looking at their survival rate, because the UK has one of the lowest survival rates from breast cancer in the world, in the Western world. And we're very lucky in this country with the support we get from government, with our GP programs and allied health, rebates from government, and the McGrath Foundation, the National Breast Cancer Centre, the BCI, of course, and the Rural Health Education Foundation. So thank all of you for coming. I hope all of you in the audience have enjoyed the program, Moving Forward and Surviving Breast Cancer. If you're interested in obtaining more information about the issues raised in the program, there are a number of resources available at the Rural Health Education Foundation website at rhef.com.au, and information on the listed websites there. And resources are also available from the BCI's website, bci.org.au, and the National Breast and Ovarian Cancer website, which is www.mbocc.org.au. Or you can ring the Cancer Council helplines for information, which are a great source of information. And don't forget, if you're one of our health professionals out there, please complete and send in your evaluation and forms for your CPD points. And for those of you who are not health professionals, we really do appreciate your feedback form, which you can download from the Rural Health Education website. I'm John Boyages. Thank you for attending, and good evening.